fine, it's really stable. The biggest request that I have is if you've got someone with a small ankle and you basically, the stirrup and the posterior slab is almost circumferential, so it doesn't allow them to swell very well, and so it'll cause them to have fracture blisters.
Okay.
So on smaller patients, sometimes if you can just get away with a stirrup, you could use the bigger 3-inch orthoglass and just do a stirrup, cheat it a little posteriorly, and that way you give the front and the back to swell. That sometimes works a little better than cramming everything together, and you're basically putting a cast on the acute fracture. That's one, I guess, trick with the lower extremity that I would caution on. The upper extremity stuff, classically, if you've got a distal radius fracture that you think is pretty unstable, then we typically would recommend a double sugar tong, or at least a stirrup going around the elbow to prevent pronation supination, because that's what causes instability and it can fall off. So you could do at least around the elbow, make sure you're wrapping all around, and then if you want to put another one up the bicep, that gives it even more stability. That's the other trick. Shoulder stuff, I mean, are you guys doing like Sarmientos or like big hanging ones for proximal humerus fractures? You're just hanging them, right?
Yeah.
Put them in a splint, hang them.
Yep,
I agree.
Sling or a splint, whatever is.
There's kind of new data that's come out where that big old casting technique really doesn't work very well, so they just let them hang in a sling. Same with like clavicle fractures. They've really gotten away from even the figure 8 braces they used to use.
I saw that.
They just kind of put them into a sling and say, hey, let them rip. And then we'll look at them and follow them. It's very rare they need surgery, so usually that's okay.
You usually make that decision on a case-by-case basis. Cause, I mean, is there an angulation or a fragment separation that you look at?
Yes, I mean, it's how bad is it tenting the skin, which is hardly ever too much. I mean, I've got that's horrible and it's fine, right? I mean, it's probably the kid who might be a D1 athlete who's a pitcher or a quarterback or someone who's going to use their arm a lot that, maybe there's some benefit in making it perfect, but that surgery is not without complications. You got a big old plate sticking there, and so you got to take it out. So very case by case, 98% of the time it's non-op. So we're just following those, and most of the time it's teenagers and 20-year-olds, and they heal pretty good.
We had a kid from where I'm from. He's probably gonna play Division I golf, and he broke his clavicle playing basketball. And they actually Jim Mantone plated it.
Did you fix it?
And he just had the plate out about 3 months ago. He's fortunately doing great.
It's awesome. Yeah, I mean that most of the time it goes well, but if you get a non-union, you're just like, God, why did we do that? But very infrequent would we fix them, and it'd be for those kids that have potentially future scholarship. What else? Most like patella fractures or distal femur fractures is neomobilizers. I don't know if you guys have hinged knee braces. You do. You could save them a little expense. I don't know how the reimbursement is, but for most everything, if you're going to use a neomobilizer, we're almost always going to use or transfer them to a hinged knee brace. The T-scope hinge knee braces, is that what you guys have?
Where you have the flexion, you can do it to 0.
Exactly, you dial them in. So if you wanted, you could put them in one of those and just lock it, because that way we don't have to charge them for the mobilizer and then charge them for the knee brace the second time. Just lock them out and that. And quite frankly, those are usually more comfortable anyway. On those, when you wrap that strap all the way around, they always have an excess amount of strap left. And then the Velcro has like a little butterfly that has Velcro on it. So you can cut the strap back as far as you need to go and then Velcro the other Velcro piece on. You'll know what I'm talking about when you see it. I could grab one if you want me to show you, but you can dial in those straps, because otherwise the straps almost wrap all the way around the brace and it becomes cumbersome and they come off and it just is annoying. So you can cut those straps to the length that's appropriate and then put the piece on and it'll fit more appropriately. But yeah, most all knee stuff, you know, whether you think it's an ACL, whether you think it's whatever, just put them in a hinge knee brace because we're going to use that anyway. What else?
What about a distal non-displaced fibula fracture?
Boot them.
Yeah.
Yeah.
You're fine booting
I
those.
am. Yeah, the boots that you guys have are pretty good. If there is a little bit of displacement or something like that, then you know you could always splint them if you wanted. But yeah, because same thing, most of those folks are going to get a boot anyway. Even if they had surgery, I'm going to put them in a boot eventually. So it's a tool that we're going to utilize. Saves you guys some time, you know, and effort. If it is a truly a bad fracture, maybe a bimal that's potentially unstable, then I would prefer splinting. And quite frankly, patients tolerate that, I think, a little bit better anyway, just because it's a little more form-fitting when you put them in a splint. You can, pad them up with the cast padding quite a bit to give them a little bit of swelling room. Whereas the boots are they're kind of rigid, they're not overly comfortable.
Right.
I think patients tolerate the splints better than they do the boots for those bad ones. Again, isolated lateral mouth, sure, they'll tolerate that. And if there's any question, I just make them non-weight bearing. I'm going to see him typically that Monday following anyway, and then you can let me make the decision on whether to weight bear them or not. That takes the pressure off you guys, and do whatever you want that way.
How often do you use them boots for ankle sprains?
It's really about weight bearing. If they can't weight bear, if they're pretty miserable and they're struggling, then I'd put them in a boot. Do you guys have the option of short boots versus tall boots?
I don't know what we have.
I don't
Okay.
think so.
Mainly just tall. Again, not a big deal. Some of the younger patients that are going to get better in 2 weeks, you put them in a short boot. It's just a lot easier for them. It's more comfortable. But if you got a patient that you feel like they're going to need it for longer, maybe a older patient that needs more stability, tall boot. But if you don't have the option, just put them in a tall boot and be done. Foot fractures, again, very rarely would you need a cast for a foot fracture. Most of the time, if it's a metatarsal fracture, even toe fractures sometimes, post-op shoes. Do you guys have the good, like the Darko post-op shoes in the ER? Is it all, see the trainer that's supplying it? Yeah, so you've got the good ones.
Okay.
There's really crappy ones that are just terrible. Patients hate them, and we always give them another one, so they have to pay it twice. So we like to give them a good one up front, and see the trainer has good stuff.
Okay.
So most foot fractures, you put them in a post-op shoe. Even like toe fractures, I'd recommend a post-op shoe, because for that first week or two, they can't get into a regular shoe. It just hurts too badly.
Okay.
So post-op shoe on that. So that's foot. We got ankle.